बाद कैमरा अपने आप वो हो जाता है, बंद हो जाता है। अब जैसे रिकॉर्डिंग चल रही प्रॉपर तो कैमरा ऑन रहेगा। हाँ, जैसे प्रॉपर रिकॉर्डिंग चल रही है तब तो कैमरा ऑन रहता है, कुछ सेकंड बाद अपने आप कैमरा बंद हो जाता है। उसके लिए जैसे हल्का सा यू दबाएंगे फट जाओ। हाँ, हाँ है कार्ड है। बस हमें यहाँ हो जाता हो जाता है
हाँ
उसमें उसमें भी हो जाता दिक्कत हो जाती है अभी अभी देखिएगा हमें यहाँ बंद हो रहा है
जान नहीं तो रिकॉर्डिंग अभी करना ना जब चालू हो जाएगा तो रिकॉर्डिंग होगा
वही
रिकॉर्डिंग करना कैसे रिकॉर्डिंग ठीक है नहीं आप बेटा आ जाएगा बेटा आ जाएगा एक कार्ड
शादी
चालू रिकॉर्डिंग आप मैंने क्या दिया जा रहा है
our program. Namaste and a very good morning to everyone assembled here. I feel extremely privileged to welcome you all in our second international conference under Mission Niramaya, organized by the Samarpan Institute of Nursing and Paramedical Sciences in association with the Pushpanjali College of Nursing, Agra, UP. We are also associated with the OET, EBAC and the CBS. Today we are organizing pre-conference workshop on simulation-based clinical practice. So we are very happy to connect with many colleges, not only Uttar Pradesh, but also in the different states of India. We also got registration from Jaipur, Shimla, Jharkhand, etc. So we are very happy to connect each and college, and we come together here to. So the world is full of diamonds and gems, and we are having some of them here today to build this event. We have in our inauguration session as event time 11 o'clock, but we don't want to delay more, so we will start our session. Then in between we will give the inauguration session when the chief guest and guest of honor will join with us. So before we start the session, may I ask our audience and our respected delegates, respected dignitaries to be kind enough to stand up for the national anthem. भारत माता की जय। भारत माता की जय। So now we are going to start our session first. So we all know that postpartum hemorrhage is a potentially life-threatening condition that persists as a leading cause of maternal death. It occurs mostly during the third stage of labor, and AMTSL, that is active management of third stage of labor, can prevent its occurrence. So let us know recommended information regarding the AMTSL by our first speaker of this event. Before we go to the session, I am just giving some brief introductions of Madam. Madam. Ma'am has completed her MSc Nursing in OBG specialty from the Rajiv Gandhi University Health Science, Bangalore. Ma'am developed the EBG on the conflict reconcile model. Nurses quality control model of healthcare system with Deepti Madam. Ma'am was a resource person for the workshop on newborn resuscitation, Noida International University. Ma'am is a resource person in a webinar on the importance of HPV vaccine in the adolescent girl. Ma'am also a resource person in the FDP organized by the Noida International University on topic on basic skill for leadership and the excellent. Won the third prize in the poster presentation on the obstetrical emergencies. Ma'am participated in the CME organized by the Subhati Medical College, Medar. So ma'am, I request you come on and ask. Okay. So we are just waiting for some time for the session. First we will go for the inauguration session, then we will move on to the session. This one. Sorry for the interruption. Our chief guest is on the way, so we are waiting for her. We are waiting for him, and we'll start from the inauguration session, and we'll move on to the session. very good morning to all. And we welcome you all in our second international conference organized by the Samarpan Institute of Nursing and Paramedical Science in association with the Pushpanjali College of Nursing, Agra, Uttar Pradesh. We are also associated with the OIT and event and ECDS. So before we start our session on event, I request to invite BSc Nursing second semester student for the welcome dance. May the Nat Lal always bless you. A very happy Krishna Janmashtami to you and your loved one. So already I have told that the world is full of diamonds and gems, and we are having some of them here today with us to build this event. With this note, now I would like to give my hearty welcome to our dignitaries, delegates, all resource persons, beloved participants, and my own friends. Now I would like to welcome our chief guest, our chairman sir, Professor Dr. R.S. Dubey sir. Sir, please kindly occupy your seat on the dais. I request our volunteers to accompany sir. Now I would like to welcome our guest of honor, Mr. Rajesh Gupta, Director, Pushpanjali College of Nursing, Agra, UP. So please kindly come to the dais and have a seat. I would like to welcome our director sir, Dr. V.P. Tiwari sir. So please come on the dais and occupy your seat. Now I request our special guest, Madam Pinky Devi. Kindly ma'am, kindly come on the dais and have a seat. Speaker as well as special guest, Madam Infant Rani Augustine ma'am. Kindly come on the dais and have a seat. Now I would like to call our principal ma'am, Dr. Deepti Shukla. Ma'am, kindly come on the dais and occupy your seat. Thank you ma'am, thank you sir. Light is a symbol of brightness and prosperity. So before we start our event, I invite all our respected dignitaries for the traditional land lighting. Thank you, sir. Thank you, ma'am. Please have a respectful seat. like to call Madam Dr. Deepti Shukla, Principal, Samarpan Institute. Ma'am, kindly come on and dais and deliver a welcome address.
Jai Hind, a very warm good morning to one and all present on the dais, off the dais and online. This international conference and pre-conference workshop is built with the intent of active and inactive learning activities that is organized by Samarpan Institute of Nursing and Paramedical Sciences in the association with Pushpanjali College of Nursing, Agra. In the presence of God Almighty, I heartily welcome our today's all the guests present in the hall. Serving the society is foremost principle on the agenda on its aim. Retired Director Ramanand Lohia Sansthan, founder of Samarpan Group, his medical services have made a difference the learner community in the good community. Professor Dr. R.S. Dubey sir. May I request Mr. O.P. Sharma sir to welcome Chairman sir with the floral bouquet. The only one man who took all the hardest of his life and hold the goods of the society to serve better and better. That Director Pushpanjali College of Nursing, Mr. Rajesh Gupta sir. May I request Ms. Pooja Prege Singh to welcome sir with the floral bouquet. Welcome you sir. An eminent scholar and a man with a full of energetic knowledge. Retired Director from Forestry and serving to the community without any cost. Director Samarpan Group, Dr. V.P. Tiwari sir. I request Ms. Manisha David if she is here. If she is not here, I request Ms. Pooja to welcome Director sir with the floral bouquet. My special welcome to today's speaker, Ms. Pinky Devi ma'am. She is a professor in Hera University, Lucknow. I request Mrs. Sunanda to welcome Pinky ma'am with the floral bouquet. The indeed detail will be told by Sunanda in the later session. We welcome you ma'am. Thank you. I do welcome Ms. Infant Rani ma'am. She is a professor in Government College of Nursing, Badaयूं. I request Mrs. Pragya Singh to welcome to the Infant Rani ma'am with the floral bouquet. We welcome you ma'am for the today's session and today's workshop. I do welcome our next speaker for today's Mrs. Sunita Bhatt. She will be joining us after the lunch. She is an associate professor in IIT University, Meerut. I do welcome Mr. O.P. Sharma. He is also today's speaker, associate professor Samarpan. And my special welcome to Dr. Alka Saxena ma'am. She is a principal in Government College of Nursing, Gorakhpur. We welcome you ma'am. Madam is in all this session from tomorrow conference and she is here with us today. We welcome you ma'am. I do welcome Dr. Sarika Saxena ma'am. She is a Vice Principal Government College of Nursing and in Gurugram. Welcome you ma'am. I extend my heartiest welcome to all the respected faculties who have taken so much of pain to take their students to this pre-conference workshop. I welcome all the dearest faculties to the workshop. welcome again. I love to welcome all the loving students from different colleges, from different part of the country. We welcome you all to such a wonderful conference. You are going to enjoy the whole day. We welcome you all. I extend my welcome to all the technical and non-technical people who are inside and helping us directly and indirectly to the session. Thank you so much for coming. We welcome you all. Thank you so much.
Thank you, ma'am. Now I'd like to call our Director, Sir Dr. V.P. Tiwari. Sir, kindly come here and address to gathering some valuable words.
नमस्कार। आज के समारोह के मुख्य अतिथि प्रोफेसर डॉक्टर आर एस दुबे, चेयरमैन समर्पण ग्रुप, विशिष्ट अतिथि CMA राजेश गुप्ता, डायरेक्टर पुष्पांजलि कॉलेज ऑफ नर्सिंग, प्रोफेसर पिंकी देवी फ्रॉम कॉलेज ऑफ नर्सिंग इरा यूनिवर्सिटी, मैडम अगस्टिन एसोसिएट प्रोफेसर कॉलेज ऑफ नर्सिंग फ्रॉम बादामी, चेयरपर्सन ऑफ द कॉन्फ्रेंस डॉक्टर दीप्ति शुक्ला, who happens to be the principal of our college also, Dr. Saxena, both Saxena squares. I look like two sisters. Principal pharmacy college, faculty from other college, all the students from different part of the states and different part of the states in our country also. Today I think we have about 450 delegates in this pre-workshop. जैसा कि आप सबको पता है, सिमुलेशन बेस्ड क्लिनिकल प्रैक्टिस ये प्री कॉन्फ्रेंस वर्कशॉप है, जिसके लिए शायद पता भी होगा 5-6 जो हमारे वर्किंग स्टेशन है जिनमें लोगों को ट्रेनिंग दी जाएगी। मैं समर्पण परिवार की तरफ से आप सभी का हार्दिक स्वागत और अभिनंदन करता हूं और यह आशा करता हूं कि हमारे जितने भी एक्सपर्ट्स हैं, जो लोग बाहर से आए हुए हैं, जो हमारे छात्र छात्राओं को सिमुलेशन की ट्रेनिंग देंगे, उनके ज्ञान से बच्चे ज़्यादा लाभान्वित होंगे और आगे चलकर एक क्वालिफाइड नर्स के रूप में जब इस संस्थान से या अन्य संस्थानों से जहाँ से गए वो निकलेंगे तो समाज की हेल्थ केयर सेक्टर में एक बेहतर सेवा कर पाएंगे। इन्हीं शब्दों के साथ मैं पुनः आप सबका हार्दिक स्वागत और अभिनंदन करता हूं और ये आशा करता हूं कि 4 दिन समर्पण संस्थान में आपका ये स्टे सुखद और लाभप्रद होगा। धन्यवाद, नमस्कार, जय हिंद।
Thank you, sir. Now I would like to request our chairman, sir, Samarpan Group, Professor Dr. R. S. Dubey, sir, please come and address the gathering with some motivational words.
आदरणीय डायरेक्टर राजेश गुप्ता जी, डॉक्टर तिवारी, मैम अगस्टिन, मैम पिंकी देवी और चेयरमैन डॉक्टर शुक्ला, हमारे समूह बैठे सभी प्रिंसिपल्स, फैकल्टी मेंबर्स, गेस्ट एवं छात्रों, आप सब जानते हैं कि आप यहाँ क्यों आए हैं, नब क्यों बुलाया है। उन बातों का विजिट करना बहुत परफेक्ट नहीं होता, लेकिन हाँ मैं ज़रूर इस कैंपस में पहली बार आने के लिए मैं आपका हृदय धन्यवाद देता हूँ और ये उम्मीद करता हूँ कि ये आपका ये क्लिनिकल सिमुलेशन बेस्ड प्रैक्टिस है, ये आपके काफ़ी फायदेमंद होगी। पहले आज से कुछ वर्ष पहले एक्चुअली यूपी में मैं कह सकता हूँ कि 10-15 साल पहले नर्सिंग कॉलेज बहुत ही कम थे और थे भी बहुत गवर्नमेंट के और नॉमिनल, बच्चे बहुत कम होते थे, तो काफ़ी कुछ सीखने का मौका मिलता था। लेकिन अब बहुत से कॉलेज हो गए हैं, बहुत छात्र हो गए हैं, अफतारों की संख्या तो बढ़ी है, लेकिन आपस में सीखने सिखाने की प्रवृत्ति काफ़ी कम हो गई है। सरकार के नियम सख्त हो रहे हैं और होना भी चाहिए, क्योंकि आप मानवता की सेवा के लिए आपने कसम खाई है और आप एक जिंदा इंसान के साथ काम करते हैं, और कोई भी जिंदा इंसान अपने ऊपर प्रैक्टिस करने नहीं देता है। वो मुझसे डरेगा, भय खाएगा, शिकायत करेगा, बहुत सी चीज़ें होती हैं। उसको मद्दे रखते हुए ये विधाएं डेवलप की गई हैं सिमुलेशन बेस्ड, कि आप एक्चुअली जैसे आप यू आर वर्किंग ह्यूमन बीइंग, वैसे ही सुविधाएं आपको दी गई हैं, आपको ट्रेनिंग दी जाएगी, उसका ज्ञान आप प्राप्त करेंगे। तो एक कॉलेजेस का विषय निर्यामक के तहत ये एक अच्छी विधा है, अच्छी सुविधा है, जिसका आप भरपूर फायदा उठा सकते हैं। मैं ज़्यादा समय नहीं लेना चाहता, क्योंकि आपका समय बहुत कीमती है, समय कम है, सीखना बहुत कुछ है। बस मैं इतना ही कह के अपनी बात समाप्त करता हूँ कि बच्चों, आप यहाँ आए हैं, आपको आने में, जाने में, रुकने में बहुत सी असुविधाएँ हो सकती हैं। इसके बावजूद आप मन लगा करके जो समय आपके पास 4-5 घंटे आज का है, इस सिमुलेशन बेस्ड प्रैक्टिस को जरूर सीखेंगे, प्रैक्टिस करें और ज़्यादा से ज़्यादा ज्ञान लेकर के आप यहाँ से जाएं। बस इन शब्दों के साथ पुनः आप सबको मैं धन्यवाद देता हूँ। धन्यवाद।
Thank you, sir. Now I'd like to call our guest of honor, Mr. Rajesh Gupta, Director, Pushpanjali College of Nursing, to address a vote of thanks in this inauguration session.
सभी सम्मानित मंच पर उपस्थित लोगों का बहुत बहुत आभार कि आप लोगों ने इस अंतर्राष्ट्रीय कॉन्फ्रेंस के लिए और प्री वर्कशॉप के लिए समय निकाला। माँ सरस्वती से वरदान प्राप्त सभी रिसोर्स पर्सन का आभार कि आप लोग अपना बहुमूल्य ज्ञान अपने बच्चों को, अपने अनुजों को प्रदान करेंगे। सुशोभित सदन जो ज्ञान प्राप्त करने आया है, उन सबका आभार, क्योंकि आपके बिना ज्ञान देने वाले भी अधूरे हैं। मैं इस आभार विधि के साथ साथ आप लोगों से, पूरे हिंदुस्तान के नर्सिंग कॉलेज के प्रिंसिपल से निवेदन करना चाहूँगा कि जब कभी भी आपका मन करे, आप अपने कॉलेज के बच्चों को आगरा, वृंदावन, पुष्पांजलि घुमाने लाएं, जब भी मन करे। और जब भी पुष्पांजलि कॉलेज से किसी भी कॉन्फ्रेंस का न्योता कानों में सुनाई दे जाए, चूकिए मत। एक जिद पकड़ लीजिए कि हमको तो जाना ही जाना है, क्योंकि आपके प्रोफेशन में जितनी कॉन्फ्रेंसेस आप अटेंड करेंगे, जितना आप लोगों से इंटरेक्ट करेंगे, वो ही आपके लिए लाभप्रद है। उसी से आप जहां आज आप रिसोर्स पर्सन को देख रहे हैं, वहीं आप पहुंच पाएंगे। तो जब सुनेंगे तभी सुना पाएंगे। थैंक यू।
Thank you, sir. Now I request all the dignitaries to please come off the dais, and we will move to for the high tea. So we'll take 15 to 20 minutes for the high tea. I request all the delegates to come back by that 15 to 20 minutes so that we will start our session. I request our volunteer to escort our dignitaries, special guest, speaker and chairperson and organizer, faculties to go the right side of the auditorium, and I request all the delegates to go the ground for the high tea. I request our volunteers, please accompany with the speaker, chairperson, dignitaries, and organizer. And all delegates are requested to go the ground and enjoy your tea.
है कहाँ चाय पिए
वो सब सही है, ये जो वर्चुअल लगा दिया ना।
हाँ हाँ हो गया था हैं? अरे ये सब धीरे धीरे मालूम हो जाएगा तो कोई दिक्कत नहीं होगी उतना। ये तो कहिए न इतना अच्छी किस्मत थी कि डोंगन मिल गया, नहीं तो डोंगन जो है मैं मिलता तो बड़ा सरदर्द
बात तो सही कह रहे हैं, किसी का कमाल
चल रहा है नहीं रिगार्डिंग मैं आपको अभी बोल रहे
हम आपका
इसलिए तो मैं रुका हूँ मार्केट में तो
All the delegates are requested to seat so that we will start our session.
वही लिंक रहेगा ना यूट्यूब वाला
वही चार्जिंग हटा देंगे चार्जिंग आ रही है हाँ अच्छा मेरा बंद हो गया मेरा चार्जिंग
So I welcome you again in our second international conference organized by the SINPS in association with the Pushpanjali College of Nursing, Agra. So we will move to the first session. So already I have told and we all know that the postpartum hemorrhage is a potentially life-threatening condition that persists as a leading cause of maternal death. It occurs mostly during the third stage of labor and AMTSL can prevent it occurrence. So let us know the recommended information regarding the AMTSL by our first speaker of this event, Madam Professor Pinky Devi. Before I will request to come on a dais, I just want to give some brief information about you. Ma'am has completed her MSc Nursing in OBG specialty from the Rajiv Gandhi University of Health Science, Bangalore. Ma'am developed EBT on conflict reconciled model. Ma'am also developed the nurses quality control model of healthcare system with Deepti Madam. Ma'am was resource person for the workshop on newborn resuscitation, Noida International University. Also, Ma'am was resource person in webinar on the importance of HPV vaccine in adolescent girl in January 2022. Ma'am was resource person in FAB organized by the Noida International University on topic basic skill for leadership and excellence. Ma'am won the third prize in poster presentation on the obstetrical emergencies. Ma'am participated in CME organized by the Subarthi Medical College. So I would like to call Ma'am on a dais and start, ma'am, your presentation, ma'am. Thank you, Sunanda, for a wonderful introduction. Good morning to all the delegates present here. My seniors are sitting in front of me, Dr. Alka, Dr. Shikha Madam, Dr. Santosh, my friend Madam Infant Rani, and Dr. Dipti. Thank you so much for giving me this opportunity. And in front of me, Shri Rajesh Gupta, Director, Pushpanjali College of Nursing. Good morning, sir. And good morning to all the delegates present here, faculty, PhD scholar, BSc nursing student, PG students of nursing. Good morning to all. Today we will discuss on active management of third stage of labor. The objective of the session will be introduction to normal labor, stages of labor, about active management of third stage of labor, the steps need to be followed on active management of third stage of labor, and the reference. I will not take much time on narrating about labor. Just we will have a review. Labor is a process in which viable fetus is expelled from the uterus. A normal birth is defined as spontaneous in onset, low risk at the start of labor, and maintaining so throughout labor and delivery. The infant is born spontaneously in the vertex position between 37 to 42 completed weeks of pregnancy. This statement is given by WHO, World Health Organization. What are the stages of labor? There are 4 stages of labor. The first stage, second stage of labor, third stage of labor, and fourth stage of labor. Alright. Let's move to my next slide. First stage of labor, it is the stage of cervical dilatation with the onset of true labor pain and ends with full dilatation of the cervix, that is 10 centimeter in diameter. It takes about 10 to 14 hours in primigravida and about 6 to 8 hours in multigravida. This is how when the cervix is full dilated, the fetus head will descend down. In the second stage of labor, it starts. The stage is started from the expulsion of fetus, begins with full cervical dilatation and ends with the delivery of the fetus. The duration of it is about 1 hour in primigravida and half an hour in multipara. In the third stage of labor, the stage starts with the expulsion of the placenta and the membrane, begins after delivery of the fetus and ends with the expulsion of the placenta and membrane. The duration is about 10 to 20 minutes in both primi and multigravida mother. So in this stage, the delivery of the placenta will take place. And the last one is the 4th stage of labor. It is the stage of early recovery, begins immediately after expulsion of the placenta and membrane and lasts for approx 2 hours. Now the question is, why active management in the 3rd stage of labor? Many research has done under this topic, and research has found out that this is the very effective mode of management where many benefits are there. Therefore, we have started taking up we started practice of active management of 3rd stage of labor now. Now, what is the physiological management? Let us see in the next slide what are the difference. Here, uterotonics drugs is not given before delivery of placenta in case of physiological management. This is what earlier we practiced before coming to active management of 3rd stage of labor. Uterotonics drugs is given in case of active management of 3rd stage of labor within 1 minute of birth of baby. That is injection oxytocin. If it is not available, then tablet misoprostol is given to the mother within 1 minute of delivery of baby. When we come to the sign of placental separation, in physiological management, earlier we used to wait for the sign of separation of the placenta. Here are the symptoms we used to check, that is gush of blood, lengthening of the cord, uterus become rounder and smaller as the placenta descend down. In active management of 3rd stage of labor, we are not waiting for the sign of placental separation, which earlier we practiced. Instead, palpate the uterus for contraction, wait for uterus to contract, apply control cord traction by counteraction. This is how the difference. And in the uterus massage, both physiological management, massage of the uterus after placenta is delivered, in same manner in the active management also we practice this both. Let us see what are the advantages. In the physiological management, does not interfere with normal labor process, does not require any specific drugs like injection oxytocin or tablet misoprostol, may not require any birth attendant with injection skill. Whereas in the active management of 3rd stage of labor, what are the advantages in this? Decrease length of 3rd stage, decrease likelihood of prolonged 3rd stage, which will prevent PPH. Then decrease average blood loss to the mother, which is a very alarming condition in India till today. Maternal mortality rate is very high in India, and UP government is also very much focused on that to reduce the maternal mortality rate. That is how we started developing this practice, active management of 3rd stage of labor. This will help to decrease the blood transfusion. What are the disadvantages? There are few disadvantages also in the physiological management. Length of 3rd stage is longer compared to active management of 3rd stage of labor. The blood loss is more compared to active management of 3rd stage of labor. Increased risk of PPH. Whereas, what are the disadvantages in active management of 3rd stage of labor? It requires uterotonic drugs. It's compulsory we require these drugs, injection oxytocin or tablet misoprostol is required. We require birth experience or skill in injection provider, and who are skilled in using control cord traction, which after this session we will be practice hands-on training in our station, that how are we going to apply this method. Alright. Let us understand how to perform active management of third stage of labor. There are steps. The first step is administration of uterotonic agent after delivery of the baby. The second step is expulsion of placenta with control contraction. Alright. The third step is uterine fundal massage after expulsion of the placenta. Now, in the first step, palpate the mother's abdomen to exclude the presence of another baby. This is very important. We need to rule out before giving injection oxytocin. We need to confirm by palpating the mother's abdomen that second baby is there or not. If it is there, then we cannot give this injection. We have to wait for the delivery of another second baby. Then we'll go for the injection. Okay, the next step is uterotonic drugs. That is what 10 international unit of oxytocin we need to give in the anterolateral aspect of the mother's thigh, or if it is not available, then we can give tablet misoprostol 600 microgram orally. This will help the uterine contraction and hence it will help in placenta delivery and reduce the blood loss, prevent from PPH. Complete drying and wrapping of the crying baby and give injection oxytocin in first minute. I mean within 1 minute of delivery we must do quickly. Continuous essential newborn care we need to provide. Check for cord pulsation. Clamp the cord with artery at 2 places. When cord pulsation stop, put the first one at least 3 cm away and the second one the 5 cm away. Umbilicus. Cut the cord between the artery clamp with a sterile scissor by placing a sterile gauze over the cord and scissor to prevent splashing of blood. This is how we will cut. This is how the 2 clamp, and then it will cut after pulsation stop. Apply the disposable sterile plastic cord clamp tightly on the cord. Yes. Yeah. This is the disposable sterile cord clamp. This is how you clamp the cord. Place the baby in between the mother's breast to maintain temperature and to prevent from hypothermia. This is how you will keep your baby in between the mother's abdomen. This is how the nurse midwife will encourage the mother to keep her baby as soon as the baby delivers. Put the identification tag on the baby. Cover the baby's head with a cloth. Cover the mother's and the baby with a warm cloth. This is how you will put the identification tag. Second step, control contraction. Attempt only when the uterus is contracted. I repeat, you should attempt only when the uterus is contracted. Assure the women that delivering the placenta is not hard because it is much smaller and softer than the baby. Clamp the maternal end of the umbilical cord close to the perineum with an artery clamp. Hold the clamp and with one hand and place the other hand just above the symphysis pubis for counter traction on the uterus to prevent inversion of uterus. This is how you will apply the control cord traction. Only during contraction, gently pull the cord downward and then forward to deliver the placenta. With the other hand, push the uterus upward by applying counter traction. As the placenta appears at the vaginal introitus, hold it with both the hand and twist it clockwise to deliver it complete and prevent tearings of the membrane. So this is how you will apply your hand in the abdomen. Keep gentle twisting of the placenta with membrane so that they get twisted into a rope and expel and slip out of the introitus intact, and place the placenta in the tray. Now next, the last step is uterine massage. Place the palm on the uterine fundus and feel for the step of contraction. If the uterus is soft and not contracted, then you have to repeat the massage the uterine fundus in a circular motion with the cup palm until the uterus is well contracted. A well contracted uterus will feel like a cricket ball or a forehead, how hard it is, the cricket ball, like that the mother's uterus will be when you palpate in her abdomen, and then you can assume that yes, the uterus is contracted. When the uterus is contracted, place her hand behind the fundus and push down in one sweep to expel all clot. Examine, estimate and record the amount of blood loss approximately. Encourage the attendant to help the women for breastfeeding. Examination of the lower vagina and the perineum. Gently separate the labia and inspect the perineum and vagina for bleeding or any kind of laceration or tears. Clean the vulva and perineum gently with warm water or an antiseptic solution and dry with a clean and soft cloth. Place a pad and remove soiled linen to make the woman comfortable and sweep her up to lie comfortable on the delivery table. Now next is the examination of the placenta membrane and the umbilical cord. The maternal surface of the placenta need to be examined carefully. Hold the placenta in the palm of the hand. Keep the palm flat. Make sure the mother surface is face up. Check for all the lobules present and fit together. If any of the lobes is missing or the lobules do not fit together, then you can suspect that some placental fragment may have been left behind the uterus. Some may left behind the uterus, so we need to focus to clean it up all. So this is the surface of placenta, maternal side. In my left side and in my right side picture is the fetal surface. The fetal surface, hold the umbilical cord in one hand and let the placenta and membrane hold down like an inverted umbrella. Look for holes which may indicate that a part of the lobes has been left behind in the uterus. Next, the membrane. How are you going to examine the membrane? Put one hand inside the membrane and open them and see for any holes other than one from where the membrane ruptured and the baby came out. What we are going to see in the umbilical cord? Inspect the umbilical cord for two umbilical arteries and one umbilical vein. If only one artery is found, then we need to look for any congenital abnormalities in the baby. If it is required, then further referral need to inform the concerned person. This is the anatomical structure of umbilical cord. Here the blue color is the umbilical vein, and the two red color is representing the umbilical arteries. Alright. Next, the last part is the decontamination and disposal of waste, which is very important for us to understand. We need to understand the biomedical waste management. Disposal of the placenta in the yellow color contaminated waste bin. After removing the artery clamp, place the instrument. Use in 0.5% chlorine solution for 10 minutes for decontamination. Record all the important points such as date, time, delivery, gender of the baby, condition of placenta, umbilical cord, any medication given, etc. in mother's file. We will discard it in the yellow bin. And if we follow all this, then we will be able to control PPH or maternal mortality. If we are skilled enough, everyone should be skilled, and we will be able to bring happiness to the mother and the baby. Safe motherhood. These are my reference. Thank you all. And happy Janmashtami. Thank you, ma'am, for sharing your valuable knowledge with us. So moving to the next session, we are having the most important aspect or topic, we can say, that if we are looking into options for the birth control, what method we may suggest as a healthcare provider is IUD or PPIT insertion. So today our next speaker is going to explore the Ma'am, I'm taking 1 minute to give you just brief introduction about you. So please, ma'am. So ma'am has done her UG and PG from Sri Ramachandra University, Chennai. Ma'am has total 14 years of experience, out of 9 years in teaching and remaining 5 years in clinical. Ma'am has published more than 14 papers, out of which 12 are from international journal and 2 are from Scopus. Presented 3 papers in national and international conferences. Ma'am has organized international conference, national workshops, symposium, hands-on training on unitary resuscitation in collaboration with the NSS. Ma'am had been speaker for international conference at Muzaffarnagar Nursing College, holding TOT certificate from the Vidyant and SJT University, which is science and collaborations on simulation training. Ma'am currently is a PhD scholar from Swami Vivekananda Suvarti University and also currently working as an associate professor from College of Nursing Government Medical College, Badam, UP. So ma'am, now I request you to start your session. Stage is yours, ma'am.
All speakers and seniors, delegates, dear students, I'm very happy to be here as a simulation showing PP, IUCD, that is the thing, and IUD insertion. I don't have PPT also. I'm going to show the procedure. If you don't mind, can I get a mic for the next Okay, Vector arrange before they are arranging to start a session. I think I can reach the audience with my voice itself. Can you all hear? No? You will be hearing very soon. Okay. See, before that, already madam has delivered a baby. We have Yes. Hello. Next. I think now I'm hearing. I think so. Thank you all. So I started already. So madam has delivered. Now I'm going to control with how I can control the family, our children. Immediately after birth. It's not going to be a PPT or a one-way session like I'll be talking and you'll be listening. Yes. Yes. Now, you are the one going to do it and you are the one going to tell them everything. Tell me. Yes, ma'am is a senior, not from ma'am. Okay. PP, IUD. Yes or no? IUD or PP, IUD? PP, IUC. Okay, PP, IUC or PP, IUD. Okay. When I want to give my example itself. During interview, when doctor asked me what is PP, IUD, I told postpartum intrauterine device, sir. Is it postpartum intrauterine device? Very good. It is a post-placental. That is why I told madam has delivered active management of third stage of labor. Yes or no? Active management का क्या difference है? Madam has given a good session. Active management, is it necessary everyone should do active management? For all mothers? No need. Automatically also placenta will deliver. Yes or no? My voice is audible, I think so, sir. Sorry. Yes. I think, sir, आपका थोड़ा problem है. मैंने इधर उधर remove कर दिया. You have to rotate. Okay. So, madam has told active management in a third stage. आप कुछ कर दिए, नहीं कर दिए, automatically placenta will be coming out. Then why we need active management? क्यों? To reduce the duration. To reduce the duration. Instead of 20 minutes, 30 minutes का placenta expulsion का, ma'am has given a good service and you have given a active management control contraction and jaldi it has delivered. So time duration you have reduced. Okay. So after everything finished, now we are going to put a property. So post-placental intrauterine device, as soon as the placenta comes out, can we do IUD? Ma'am, one mother I have given a full session. She is not willing, ma'am. She is telling मैंने कैसे मैंने बच्चों का feed कर दिया, काम हो गया. They will have doubts, na? Mothers will have doubts. Sister, is it normal? Can I take a PP IUD? मैंने कहा कुछ body में change हो गया, दूध का दिक्कत हो गया. I'm not very good in Hindi. My Hindi will be not that much good. Okay. So these are the questions mothers will have. As a nurses, what answers we will give? There is many research is telling there is no decrease in breast milk because of PP IUD. So we can advise the mother, you can go. Nothing will happen. Okay. Next question, some cesarean mothers. During cesarean section, yes, lower segment, upper segment, that is doctor's decision. During cesarean, can we go for PP IUD? Any idea? No. Yes. No. Yes. We can go. PP IUD after cesarean. During cesarean itself, it is single procedure. Anyway, cut कर दिया, insert करो, finish करो. That is also, but everything should be done before and that means during antenatal itself we have to educate the mothers. We should get a cooperation and consent should be taken during an antenatal. It is not during intranatal. Okay, so today we will see the PP IUD and also IUD insertion. IUD insertion, we all know that we will tell when a mother is telling my sister, मैंने कहा IUD insert करना पड़ा है, when she don't want to get a pregnancy, like after during menstrual cycle or within 3 days, 5 days, you are calling and you are putting. But PP IUCD, immediately placenta comes, we can put. Okay. using. Like we have what are the types of IUDs we have? We have a copper T375, copper T388, Nova 200 है. Okay. As a nurses, being a medical professionals, when a mother comes, what we are telling? ए ले लो बहुत बढ़िया 5 साल का अच्छी हो गया आपका कुछ दिक्कत नहीं है 10 साल का हो गया. Yes or no? You are right. That only we have to do. So you all are telling copper 375, 380, whatever it may be, according to the years you are telling. Anyone knows why it is divided like a copper T 375, 380, 200? Any idea? Ma'am, according to the sol it is different. Yes? Anything else? According to the copper है ना? 200 mm है, 375 है, 380 है, and sol also 5 years, 2 years, 10 years का different है. Okay. Not from the teachers. I will show the articles students will tell, especially 4th years and MSCs. Many of them I am seeing MSCs also. Even I know Anju is there, I think so. Yes, Anju, how are you, Anju?
I'm good.
Good. Okay. First instrument itself very difficult instrument I have given you. Any idea?
Sponge holder.
Everyone sponge holder.
That is sponge holder.
Huh?
That is sponge holder.
Acha, ring forceps, very good. Sponge holding, ring forceps.
That is sponge holder.
Huh?
That is sponge holder.
Curved sponge holder. Okay. You all are little bit right. Sponge holding का क्या difference है? Did you see in a sponge holder? We will have a lock. Handle में lock आती है. In this lock is not there. Did you notice? They told ring forceps. Otherwise called as any area. Okay. During delivery we are using one pad. क्या pad है? Killis pad. Killis pad we will put under the buttocks and we will collect everything. Yes or no? This is called as Kelly's forceps. Kelly's forceps. Okay, there is no locking device nahi hai. Why there is no locking device? Actually, truth I am telling, I did not even see the tray. Directly see I came and I started my procedure. Okay, what is the difference between the Kelly's forceps and sponge holding? Locking system, very good. So PPIUD mein, when you are introducing PPIUD, you will be taking the IUD directly. Okay. You all know in IUD, ma'am, we will place the mother in a lithotomy. After placing, cleaning hai. Yes or no? Yes, cleaning we will do in IUD. I am not talking about PPIUD. We will clean, we will introduce a क्या speculum? SINPS speculum. SINPS also. Okay. Like me bada multi, they will use a broad wala. And if you are using a primary, then there is a chota head. Okay, you can use it. You are putting, then you will measure the uterus length. Yes, with the uterine sound, then you will introduce. But PPIUD में uterine sound का कुछ काम है? कुछ काम है? नहीं है, नहीं, क्यों? अभी postnatal में, immediate postnatal में uterus बड़ा हो गया. How you can measure the uterine length? So we can't measure. That is why we are using a Kelly's forceps because uterus length का we can't able to identify. Yes, our rate is very high. So directly we can take the with the Kelly's forceps, copper T. Okay. This is no one. First, let me finish the procedure by like a presentation. Then I will show you that this is I think you all know who is she, my friend. Her name is Vinita. Her name is Vinita. Mama Natalika's sister, I think so. So sister you, not mama you, you are using for only IUD का. This is a mama U. ठीक है. Okay. See. This is the main thing in a PPIUD. You are not going to measure the length also, and you are not going to use any copper T insertion device like a plunger or inserter, nothing. You will be taking out, not in your hand, just I am showing you a demo. You will be holding the copper T like this. Center mein you will hold. Okay. Okay. So that is why we don't have a we don't have a tooth like handles also. It is just we are holding like this. Okay. So now my mama is ready. So when a mama is ready, first you are cleaning everything. Already she is in a labor. Already finished. Yes or no? Second stage ho gaya. Already placenta also came out also. So immediately we can insert the PPIUD. So when you want to introduce immediately, what we can do is, अभी देखो इतना बड़ा है uterus, yes or no? बड़ा, ठीक है? So when you are introducing it, you can put a spatula. You can take a usually, देखो इधर है तो छोटा है, this side में थोड़ा बड़ा है. And one more thing, introduction also. I am also doing. Nurses, if you are seeing what we are doing, directly insert कर दिया. हाँ. कैसे insert करना पड़ा है? Very good. 9 to 6. Otherwise, first we introduce like this, then turn करो. Okay. After turning, now we have a. See now we can use it if you want. You will have a valsalam. Now I don't have valsalam. I am having sponge holding. We have to hold the anterior lip of the cervix. Can you be able to see? I think so. Yes. Now because she is an immediate postnatal, bada cervix है, bada uterus, everything is big. Yes. So. अच्छा. Thank you. Thank you. Now I have holded also. After holding, what I done with this PPIUD forceps, that is your Kelly's forceps. देखो, and did you see the manufacturing? That means how it has been made. It is not made in this side curve or something. This is made in this side curve. Yes or no? Okay. So and also one more thing. What is our normal uterus shape? How it will be? Pear shape, anteverted and anteflexed. It is not a anteverted and anteflexed. It is the anteverted. So we have to give a slight counter. Slight counter. When you are giving slight counter, थोड़ा straight हो गया. Okay. Then now. Because to see everyone I am doing here and there, but when you are getting real patient, it will be अलग ही. Okay. So you can see, देखो, can you able to see? Okay. Once you are reaching into the fundus of the uterus, okay, you will be reaching. After reaching fundus, just release. Usually it will be sitting, and you have to sweep the forceps like this. When you are taking the forceps in this direction, you may pull out the property. Okay. So after introducing inside, just like this, you have to sweep and come out. समझ आए? Okay. One more doubt. I am also having the same doubt. After introducing property, usually the thread will be long. We used to cut. In this need to be cut. No means if you say no, I'll ask question why. so we can't cut and no need to cut also. So when we can cut? After 4 weeks, okay, 4 or 6 weeks. Your postnatal period is like a 1.5 month. We are telling 6 weeks ke baad when she comes. In case you are seeing the thread outside, we can cut. So I think little bit clear idea about the PPIUD. Okay. So I told PPIUD may immediate as soon as mother has delivered the placenta, my work has started. Yes or no? Which timing is effective? PPIUD. Anyone? I will tell to Deepthi madam to give chocolate boosters. Very good. 48 hours. 48 hours. Huh? 48 hours. Okay, 48 hours is the very effective and very good. So we can do the PPIUD within a 48 hours. Maximum we can extend to 4 weeks, but within 48 hours is the very effective and good. Okay, now you all clear, I think so, PPIUD. Can we go to IUD now? So then only we will know what is the difference, how we are doing it. Can we go to IUD? Yes. Yes. Now, Mama U has finished. Now I am calling Sister U. Sister U is sleeping, I think so, in their lab. Huh? Okay. Oh my God, Sister U came from lab. Thank you. I did not see the article. What is there? That is the issue. Any doubt in a PPIUD? No doubts. Okay. I will tell one joke. One teacher was telling, he's बच्चों क्या हो गया पूरा समझ आ गया? Understand? Yes sir. Entering in your brain? Entering sir. One boy is telling entering sir. Roof में the rat is entering. अभी entering sir, not yet finished sir. Entering sir. Finished or not? अभी हो गया sir. Same like that, I think so. There is 2 category. Yes. Which category? Not rat ma'am. Literally we know ma'am. PPIUD. Yes. Please talk. Yes. Okay. Thank you. So now we have a next is Mama U. Sorry, Sister U. Sister U. Why we are telling Sister U, Mama U? Mama is immediately delivered. Sister U is after delivery, otherwise not delivered. Even it is not mandatory that only married people has to take property or something. Maybe like sexual workers is also they are taking. Okay. So next procedure we are going to see the IUD insertion. Intrauterine same property, same 380, 375 or 200, Nova 200, anything we can use. But now we have got a new one also, like the livinogestrol that has very less complications. They are telling. Okay, livinogestrol का combination है अभी नया वाला. One doctor is doing a research also. I saw her. She is doing. Okay, everything it is coming livinogestrol only, but she was telling it is has less complication because of this property 380 or something. Sometimes others are having a DUB or AUB or something they are developing, so they are telling less side effect. Now. Teachers are telling this is not session for actually teachers ka. Skill lab or simulation should be very good. Before that, today's session is a skill lab and simulation lab. Simulation training is skill training. Simulation training, yes or no? Okay. What we are giving in a simulation training? Simulation, what do you mean by simulation and skill ka kya difference? Now teachers come. What is the difference between the skill procedure or simulation ka? Ma'am, today we are going to see about IUD. IUD insertion is this, that. Skill हो गया, yeah, हो गया. Simulation में very good. Actual situation we are giving. Actual situation means either we can make a bhaiya, didi, or whoever it may be. We are going to make us a real patient. Otherwise we can give also dummy also we can give. इधर मिस्टेक कर दिया टीचर मैम क्यों कर दिया कौन कर दिया like this we are asking. In real patient if they are making we can avoid the mistakes. Okay, so now same like my classes here and there I'm going, I think so. Okay, so now we are having a Ayurveda articles. We have a uterine sound. Everything is manufactured according to our body parts. Yes or no? Like because our uterus is like this, it is anteriorly they have made, antevertally they have made. Okay. Next we have a Valsalam. Very good. Same thing. What is the purpose? Very good. Upper lip of the cervix. Any other instrument can be used, beta? Yes. Don't tell sponge holding. No. आप कुछ instrument है? Anyone? Tranquilum also we can use. Same like it will be like a single tooth, like Alice Moses. Okay. Then we have a straight scissor for cutting the sutures. Sorry, not the sutures. Okay, strings. Sponge holding for cleaning we have. Then we have a speculum. And main thing is copper tip. Okay. When you are seeing in a copper tip, main thing is we have to go for a non-touch technique. Very good. What is non-touch technique? Come, you all are better than I think so. Now we should not come. जल्दी आ जाओ. हिंदी बहुत. My students all are started to make a fun. Yesterday was Teachers' Day, so they were talking same like my Hindi. हाँ कैसे बेटा खाना खा लिया? I used to ask खाना खा लिया? They were making fun. Yes बेटा. What is non-touch technique? It should not be bored now this simulation or skill. Interesting है? Okay, very good. Thank you sir. Thank you very much sir. What is non-touch technique she is going to show? Now, always when you are opening the sterile things, we will have a like this only we have to open. We should not open like this. We will have always they will put arrow also and they will show like this. Okay. Ma'am, non-touch technique you told but you are opening this one. Very good. I think OBG they have taken very well, I think so. Okay, 1/3 of part we have to open. Then make better. Ma'am, 1/3 you did not open them. Show them. Okay.
हेलो.
Which one is plunger better? Very good.
Non-touch technique के थ्रू हम पूरा IUCD को हम टच नहीं करेंगे. हम ट्यूब को होल्ड करेंगे और प्लंगर को मिडिल से पकड़ के हम ट्यूब के अंदर इंसर्ट करेंगे.
This is the plunger. Yes, we all know that plunger is inserted in the tube, in the copper tube. She is telling we have to introduce the plunger inside the tube. That means after measuring the length of the uterus with this blue color bar is there. Yes. We have to fix the length of the uterus. Okay then.
Then non-touch technique के थ्रू हम IUCD को लोड करेंगे.
अच्छा. कैसे लोड करते बेटा?
ट्यूब को पकड़ेंगे हम.
Very good. So she is right. We have to hold the tube. We have to थोड़ा नीचे करना पड़ा ये. बाद में there is one thing. We all will do dance in a alone. When we come to the stage, we will have a collab, same like this happening. Right. Stick over. Okay. So now, don't go. You are the one going to insert and show me everything procedure. Okay. So now without done, that means without touching. This is a starting back. We have already inserted. Very important thing is we are not doing thing is. First thing is because carpet is coming from government side and private. Yes. Government. So first thing, being a nurses, what we have to mainly check? Very good. Expiry and manufacturing. Very good. Number 388, 375. Because mother is asking for 10 years, you are putting 375 means it is not good. So we have to go for 380. One which is asking for 5 years, we can go for 375. Or 2 years or 3 years, we can go for Nova. But Nova we are not using mostly nowadays. We are using property. Okay. So we have checked the expiry, everything. Everything is ready. Now better. Now she is going to introduce the property. Do we need any other things in this? Here also things are there. PP. Okay. PP? PPE kit. What is PPE kit? It's not protected to the patient personal certificate. Then, Acha. Okay. In case we are having a need, we can have a towels or sterile towels, anything. Okay. So, she is introducing the SINPS speculum. Okay, very good. 3 to 9 fix करेंगे. Very good. सर्विस के ऊपर इसको होल्ड अच्छा स्ट्रेट होल्ड नहीं करेंगे इसको 11 या फिर 100 which clock 11 o'clock or 1 o'clock very good 11 o'clock or 1 o'clock position is good why in everything in not only na nursing में whatever we are doing why if you put a why we will get yes why? I did not tell the answer for why we should hold for 11 o'clock or 1 o'clock. Why? When you are holding the 1 o'clock or 11 o'clock, when we are introducing process, not the less space. Because if you are holding at 12 o'clock, we will not get enough space. If you are holding at 1 o'clock or 0 o'clock, we will get a space. अरे ठीक है सिंगल लॉक पे अच्छा भाई बेटा सिंगल लॉक पे क्यों मल्टी लॉक वेरी गुड नॉट पेइंग कंपेयरिंग टू पेइंग क्लियर यूजुअली ब्लीड होती है ठीक सॉरी स्टेराइड है ना sterile. Okay. All right. I'm beating you, this is counter, giving opposite. Same thing when you are feeling counter in the uterus fundus, stop.
इसको हमें यहाँ प्रेशर डिस्टेंस बिल्कुल वहाँ पर पैटर्न में इंसर्ट करेंगे। इंसर्ट करने के बाद देन हम उसको गैपली रिमूव करेंगे। रिमूव करने के बाद हम इसको मेरे देखिए इसका लेंथ कहाँ
Mucus, very good.
म्यूकस देखिए जहाँ पर हमारा म्यूकस लगाएगा वहाँ पे हमारे यूट्रस का लेंथ।
अच्छा. She is right. Usually when I am asking students what is the now your uterus length, no, they will tell simply 1 minute ma'am. Ma'am 7th A ma'am. इसमें नहीं है. As she told mucus until is there only, that is the mother's length.
इसको लगाएंगे different types of insulation के पार्ट।
अच्छा.
देन प्रॉपर्टी को लेके नॉन टेक्निकल का यूज करेंगे।
क्या कवर है this one? Creative, very good.
इसको कैसे और ही एक बीच में यूट्रस को इंसर्ट करेंगे।
I think you did not set already.
हमारा जो न्यू टेक्निक है जिसको हम सर्विस के इंटीरियर रोस्टर और एक्सटर्नल रोस्टर इसको इंसर्ट करेंगे। देन हमारा जहाँ पर फर्स्ट डिलीशियस हमें फील होगा वहाँ तक हम क्या करेंगे आईसीयू को इंसर्ट करेंगे।
Okay. So
देन इंसर्ट
अच्छा ठीक है.
देन इंसर्ट करने के बाद हमें फर्स्ट डिलीशियस इसको वहाँ तक हमने इंसर्ट किया फिर उसके बाद जो हमें प्लगर दिख रहा है उसको हम जेंटली पुश करेंगे।
पुश करना पड़े, पुल करना पड़े. Very good. Push, not a pull. When you are pushing only, it will go and fix into the fundus. So when you are asking like this, doubtful questions, no student will have a critical thinking. Oh my God, she has to push up. Maybe pull, maybe push. Next time she will never forget in her life. It has to be pushed.
देन हमने क्या किया पुश कर दिया। पुश करने के बाद जो हमें ट्यूब दिख रहा है और प्लगर उसको हम स्लोली से रिमूव करेंगे।
अच्छा. Property of swimming with you.
रिमूव करने के बाद हम ये नॉन डोमिनेंट पेट में हमारे मानसिक इसको हम रखे रहेंगे। जैसे हम इसको इधर निकालेंगे इधर रिमूव करें जो हमें स्ट्रीम बड़ी जैसे स्ट्रीम हमारी लॉन्ग है तो उसको तुरंत क्या करेंगे कट कर देंगे। ट्यूब के साथ
If you are not cutting, what will happen? Well, irritation हो सकता है. During like a sexual contact also they will have a discomfort.
हम इमीडिएट कट करेंगे। आगे कटने लगे क्योंकि वो जो मेकअप होता है उसमें मिक्सअप हो जाएगा तो हम कटिंग नहीं कर पाएंगे।
हमारे सिस्टर मैंने कहा पहले ज़्यादा दिक्कत है. You did not ask me properly history. मैंने every month I am getting 2-3 times bleeding है. ज़्यादा bleeding है. What you will tell? Huh? Very good. What are the 5 warning signs?
मैम पटेला ब्लीडिंग होगा, स्टोर एब्डोमिनल पेन होगा, डिस्चार्ज होगा, इंफेक्शन ये डेविएशन है वो बाहर आ सकती है। तो ये सब हमारे कंडीशन में राइज होंगे तो हम डॉक्टर से आपका कंसल्ट करेंगे।
I think we have to give a big clap for students and teachers. For students and teachers. Because इतना students का अच्छा मालूम है means we are producing good student and good staff nurses in future.
डिस्चार्ज करने के बाद जो हमारा ये रेफर होगा इसको हम फेंकेंगे। इस पे हम क्या करेंगे मदर का नेम लिखेंगे, एज लिखेंगे, इंसर्शन डेट लिखेंगे, उसकी वैलिडिटी जैसे 10 ईयर की है तो वैलिडिटी लिखेंगे, लिमिटेड है। देन हम मदर को हम एक्सपीरियंस देंगे कि अगर बेटी 10 ईयर में आपको कंसीव करना है बेबी तो आप अपनी फुल पर जा सकते हैं।
Very good.
कंसीव कर सकते हैं।
So whenever I want, okay. Okay, you are doing whenever I got it. Answer, I got it.
रिकॉर्ड और रिपोर्ट मेंटेन करेंगे।
It's us. Okay, you've done it. This is I. One question. When I have permanent family planning
Thank you so much, ma'am.
Thank you, dear. Please continue.
Thank you, ma'am, for this information. So, back to OBG topic. I just want to move towards some pediatrics topic. So, welcome. So, the next session, the neonatal period is the most vulnerable time for a child's survival. Although the vast majority, as per some thesis, the newly born infant require intervention to breathe during the transition from the intrauterine to the extrauterine life. Approximately 10% of the life newborn requires some assistance to begin the breathing at birth, and about 1% require the extensive resuscitative measure. So now the complete information regarding the NPR, I would like to introduce our next speaker, Mr. Om Prakash Sharma. So before I will call upon a stage, I just would want to give some brief information about sir. Sir has done his MSc nursing from the TMU, Muradabad, in pediatric specialty. Sir has worked as assistant professor at Hind Institute of Medical Science, followed by Baba Institute of Nursing and Paramedical Sciences, followed by MSc Institute of Nursing, Punjab. Sir has participated in the national seminar, also the first Northern Region national workshop, different national workshop at state level conferences. Sir has organized indoor game competition at the 38th State Biennial Conference hosted by the TNI UP State Branch recently. Sir has resource person at the National Conference on Simulation in Nursing hosted by the Samarpan. Sir has completed his training on Advanced Faculty Development Program under the Yorkshire University, US, and currently Sir is working at Samarpan Institute of Nursing and Paramedical Science, Lucknow. So I'd like to, Sir, kindly come on stage and present your presentation.
a very good afternoon to all the dignitaries and delegates and student delegates. I would like to thank Dr. Dipti Shukla ma'am. She gave me opportunity to be here, and my research. So my presentation is newborn resuscitation. So I'm going to start. Before starting, once I request to say all Radhe Radhe. So the primary causes of the death is prematurity, infection, perinatal hypoxia, malformation, and other causes. Next is one is in most of cases there is SIGI is 20%. These conditions are preventable, means these conditions from the newborn, and due to these conditions there is 4 million of newborn deaths after. So in 1987, American Academy of Pediatrics needed for the patient who breathing or heart is stopped. मैंने जब कोई भी बेबी डिलीवर होता है तो उसका लंग्स है वो वर्किंग नहीं होता, मतलब इट इज नॉट फंक्शनिंग, सो वी कैन वेंटिलेट देयर और रिससिटेट मीन्स रिवाइविंग अगेन, सो वी गिव द लाइफ इन हिंदी वी कैन से पुनर्जन्म. तो ventilations are given to oxygenation when breathing is inadequate, has stopped. If heart has stopped, chest compression are given to circulate blood to vital organs. Now, CPR, resuscitation means we will provide or we will give the only positive pressure ventilation to the babies, neonate. In CPR, we will give the chest compression followed by the breathing. Got it? CPR is commonly given to a patient in cardiac arrest as a result of the heart attack. Neonatal resuscitation series of the action used to assist newborn babies who has difficulty with making the physiological transition from the intrauterine to extrauterine. The transition means in intrauterine or after the birth, baby's lungs is not working. Within 1 hour after birth, that one unique physically changes occur here, that is known as the transition. So physiology of the transition, oxygen is necessary for the survival both before birth and after birth. Lungs do not function as the source of the transport. After birth, newborn will not be connected to placenta anymore. Lungs will start functioning. जब भी बर्थ हो जाएगा, बेबी जो आपका न्यूबॉर्न है वो प्लेसेंटा से डिस्कनेक्ट हो जाएगा. अब टोटली जो बेबी है, पहले क्या है मदर से उसको ऑक्सीजन मिल रही थी, अब क्या है टोटली डिपेंड हो जाएगा किस पर, लंग्स पर. और लंग्स यहाँ पर जैसे वो इंट्रा-यूटेराइन एनवायरनमेंट में आएगा उस टाइम उसके लंग्स क्या है वर्किंग नहीं होते हैं. So normally 3 major changes occur immediate after birth. These changes are the fluid in the alveoli is absorbed into the lungs and replaced by the air. When the जो fetus है वो इंट्रायूटेराइन कैविटी में होता है उस टाइम उसके लंग्स में फ्लूइड भरा रहता है. जैसे ही वो बाहर आएगा वो जो फ्लूइड भरा हुआ है उसके लंग्स के अंदर, सॉरी उसके एल्वियोलाइज के अंदर, वो लंग्स के थ्रू क्या कर लिया जाएगा, एब्जॉर्ब कर लिया जाएगा. ठीक है, और लंग्स है वो रिप्लेस्ड हो जाएंगे बाय द एयर. द अम्बिलिकल आर्टरीज आर वेन constrict and then are clamped. This increase the systematic blood pressure. Increased gaseous distension in the alveoli, it causes vessels resistant blood flow. So, before giving the resuscitation, we have to check three things. First, the gestational age and crying or birth or brood muscle form. If these three questions answer is yes, so there is no need to give the resuscitation. And if all three questions has the answer no, there is need to required to resuscitate. Purpose of the resuscitation to establish and maintain a clear airway, to ensure effective circulation, to correct any acidosis present, and to prevent hyperthermia, hypoglycemia, and hemorrhage. Indication for the resuscitation. What are things that we can think the newborn baby or neonate is need to the resuscitation? So there is three factors: antenatal partum factor, intrapartum factor, or postpartum factor. Antepartum factors are maternal diabetes, maternal infection, hydromenus, postpartum gestations, and maternal drugs abuse like risperidone and lithium carbonate, etc. Perinatal factor, it can be radiation, maybe drugs abuse, or RS factors, or intrauterine damage. Intranatal factor, abnormal presentation of the babies, preterm labor, early rupture of the membrane, foul smell, amniotic fluid, precipitate labor, fetal bradycardia, cord prolapse, and meconium stained amniotic fluid. Narcotic administration to the mother within 4 hours of the delivery. Perinatal factors. The first 1 minute after the birth is the golden minute. So we have recognized the infant not crying, position of the head, clearing the airway, stimulating newborn, and recognize the breathing, initiate ventilation by the 1 minute. That is the parameters of the Apgar scoring: heart rate, respiratory effort, muscle tone, reflex irritability, and color. ABC of the resuscitation: airway, breathing, and circulation. In recently protocols, there is a change in CAB. Chest compression is followed by the breathing. Now it is CAB. So A established open airway, position, and suction. B initiate breathing by the tactile stimulation and oxygen. C maintain circulation, chest compression, and demedication. Initial steps. First is the thermal management. Second is the positioning. Third is suctioning and tactile stimulation. So there is 4 things to keep in mind for the successful resuscitation. First is anticipation. Second is adequate preparation. Third is initial establishment and evaluation. Timely recognize, quick and correct action. Anticipation of the resuscitation. Resuscitation must be anticipated every birth. ऐसा नहीं कि सभी बर्थ को देना है कि जितने भी बच्चे पैदा होंगे उनको हम रिससिटेट करेंगे नहीं, लेकिन हमें उसके लिए ऑलरेडी क्या रहना है, एकदम रेडी रहना है, ठीक है। एवरी बर्थ अटेंडेंट शुड बी प्रिपेयर्ड एंड एबल टू रिससिटेट। जो भी बर्थ अटेंडेंट है they should be and they should have the skill for the resuscitation, and they can do resuscitate. Adequate preparation for the resuscitation. So we need to some equipments for a successful resuscitation. We will see one by one. First is clamper and cord cutter. The clamper is used to clamp the umbilical cord, and cord cutter is used to cut the cord. Next, for thermal control. It is very important because after the newborn babies come in extra environment, they lose their body weight due to the heat loss. So we have to protect them. So for that we need the thermal control. There is radiant warmer. Next, if radiant warmer is not available, we can use warm blanket there. For initial assessment, we need a stethoscope. Or for airway patency, airway patencies need to clear the airway, and because if airway is not open, the positive pressure we can't give adequately or properly. And suction catheter, mechanical suction apparatus. It can get be in hospital setting, but if there is if you are in labor room or pediatric room, if any newborn or neonate need the resuscitation, we can use the blood syringe for the meconium aspirate. I will show you mouth aspirators and meconium aspirators. Blood syringe, I am talking about this. For oxygenation, check the oxygen supply, flow meter and humidifier. For PPV, positive pressure ventilation. Positive pressure ventilation, ambu bag and reservoir. So positive pressure ventilation का मतलब ये है कि आपका जो एटमॉस्फेयर है उससे ज़्यादा प्रेशर के साथ जब आप बच्चे को एम्बू बैग के थ्रू लंग्स में एयर पुश करेंगे, ठीक है, वो होता है का PPV, पॉजिटिव प्रेशर वेंटिलेशन. फेस मास्क एंड लैरिंजियल मास्क एज ओरोगैस्ट्रिक ट्यूब, TP's resuscitator for intubation, laryngoscope or check blades. ET tube for medication. If there is seldom needed, we can use epinephrine or adrenaline, normal sign. Initial establish of evaluation, this consists from the four things. One is first we dry the baby, second positioning. Positioning is slightly head extended position we will do, that is known as also sniffing position. Suctioning and tactile stimulation. This should be only take approximately 20 minutes. Means that initially establish that step only, means including four things: drying, positioning, suctioning and tactile stimulation. It should be complete in the 20 seconds only. Open the airway. Put the babies on its back and position head to that is slightly extended. The upper airway, first we will suction the mouth, then the nose. If there is no crying, assess the breathing. If the chest is rising symmetrically with the frequency greater than 30 beats per minute, no immediate action needed. If the chest rising like that and that is visible, you can observe there is no need to immediate action. Means there is no need to resuscitate the baby. If the newborn is not breathing or gasping, in case if there is totally absent of the breathing, or baby is gasping. Gasping means baby is taking breathing like that. Like that. Immediately start resuscitation. So we should start resuscitation. There are two techniques to provide the breathing. One is first technique is artificial respiration. Only when we will use that time we don't have the sufficient articles. Otherwise, there will be chances of the infection to babies. Second, positive pressure ventilation by the amoeba or appropriate mask. Technique for the artificial respiration: clear the mouth, mucus, and slightly extended neck, and seal the nose, mouth, and take the deep breath and force into the lungs. Next, when no equipment is available, mouth to mouth and nose breathing should be done. Positive pressure ventilation is the most important aspect for the newborn resuscitation. So there is two types of resuscitation bag. First is self-inflating bag, and second is flow-inflating bag. It is necessary to intubate. When we intubate the patient, there is need to flow-inflating bag. Outline procedure to ventilate. How to ventilate a newborn? Select the appropriate mask for mask size 0 for the premature babies and 1 for the mature babies. Reposition the newborn and ensure the neck is slightly extended. Place the mask on the newborn face so there is cover the chin, mouth and nose. And don't seal between the mask and infant face. Squeeze the bag with 2 fingers only. There should be noticeable rise and fall of the chest. Means the ventilation is the positive pressure ventilation is इफेक्टिवली हम जब भी उसको इफेक्टिवली मान सकते हैं जबकि आपका चेस्ट राइज हो रहा है. After giving the resuscitated positive pressure ventilation, after 30 minutes, we count the heart rate 6 seconds and multiply by the 10. If heart rate is greater than 100 beats per minute, infant has spontaneous respiration. Discontinue ventilation, provide tactile stimulation and free flow of the oxygen. If heart rate is less than 100 beats per minute, ensure ventilation with the 100% oxygen. Initiate chest compression. So chest compression, there is 2 techniques to the for giving the chest compression. Thumb technique and second is finger technique. Finger technique, we can't do like that. Both fingers should be equal. You can see in this video. So these 2 techniques, thumb technique and finger techniques. Location, depth and ratio. Location, lower third of the sternum which lie between the preferred process, and draw the line between the both nipples, and depth of the compression is infant 1/2 inch and child 1.5 inch. So ratio of the chest compression and ventilation is for adult 30 compression to breath, for infant 15 compression and 2 breath. Chest compression. Place the thumb both hands sternum while fingering encircling chest and compress breastbone with the both thumb finger. Support the back. sorry. After effectively ventilating for the about 1 minute and stop breathing, but do not remove the mask and back. Look for the spontaneous breathing. अगर आपने चेस्ट कंप्रेशन भी दे दिया, रिससिटेट भी कर दिया, उसके बाद में आपको लगता है कि पेशेंट स्पॉन्टेनियस ब्रीदिंग नहीं कर रहा है या फिर कर रहा है, तो आप उसको डिसकंटिन्यू कर दीजिए। अगर लग रहा है कि नहीं कर रहा है, ठीक है, तो आप कंटिन्यू रख सकते हैं। A newborn will be benefited from the if breathing is slow, less than 30 beats per minute, or there is chest running, continue ventilate and ask for the arrangement of referral if possible. A newborn will be benefited from the transfer only if the properly ventilated, kept warm during transport, breathing slow and frequency of the breathing is less than 30. आप ट्रांसपोर्ट करने का फायदा तभी है बेबी को, जो भी आपका जो भी आपका न्यूबॉर्न है उसको ट्रांसफर करने का बेनिफिट तभी है। एक तो उसकी जो बेबी है, ठीक है, उसकी चेस्ट इंड्रोविंग हो रही है, ठीक है, और दूसरा अगर 30 बीट पर मिनट से के आसपास उसकी ब्रीदिंग है, ठीक है, तब आप उसको ट्रांसफर कर सकते हैं। अब ट्रांसपोर्ट करने के लिए आपको वहाँ पर कंटिन्यू उसको क्या करना है, रिससिटेट करना है, मतलब आपको कंटिन्यू एम्बू बैग के थ्रू उसको ब्रीदिंग देते रहनी है जब तक कि आप हाई सेंटर ना पहुँच जाए। If there is no gasping or breathing at all after 20 minutes of the ventilation, stop the ventilation. Care for successful resuscitation. Do not separate mother and child. Provide skin to skin contact. Encourage breastfeeding. And the newborn that resuscitate at high risk of developing hypoglycemia. Observing suckling. Good suckling is a sign of the good recovery. अगर बेबी suckling अच्छे से कर रहा है तो कहने का मतलब ये एक adequate sign है किसका, कि बेबी रिकवरी कर। Drugs are the seldom needed. जरूरत पड़े तो हम ड्रग दे सकते हैं, उसमें हम ड्रग्स में दे सकते हैं एपिनेफ्रिन। और अगर वहाँ पर डॉक्टर ने कहीं मेंशन किया हुआ है कि सिरोसिस है, ठीक है, तो हम सोडियम बाइकार्बोनेट हम दे सकते हैं। तो सोडियम बाइकार्बोनेट वी कैन गिव एंड एपिनेफ्रिन 0.01 to 0.03 milligram per kg should be administration if the heart rate remain less than 60 beats per minute after a minimum of 30 seconds of the educate. Root umbilical vein and endotracheal intravenous. Volume expanders जो ब्लड के वॉल्यूम को इंक्रीज कर दें, as like NS, RL, 10 ml per kg umbilical vein to be infused over 5 to 10. Newborn resuscitation flowchart. So this is the newborn resuscitation process. First, after birth, no meconium, dry the baby. अगर meconium नहीं है तो हम सबसे पहले क्या करेंगे, बेबी को ड्राई करेंगे। अगर meconium प्रेजेंस है तो हम सबसे पहले माउथ को क्या करेंगे, सक्शन करेंगे, उसके बाद में नो सक्शन करेंगे। And dry the baby. Not breathing well or breathing well. If baby is not breathing well, cut the cord immediately. Place on the flat surface, provide warmth and position the baby with neck slightly extended. Suction the mouth and nose, stimulate and reposition. Assess breathing, not breathing well, provide bag and mask ventilation for 30 seconds. Ensure chest rise, make arrangement for the referral. Again assess the breathing and breathing is not well, call for the help and make arrangement for the referral, continue bag and mask ventilation. Add oxygen if it is available. Assess the heart rate. Heart rate is less than 100. Continue ventilation with oxygen. Provide advanced care, chest compression, and provide medication and intubation. Thank you.
Thank you, sir. Now in face, Santosh sir. And to felicitate our guests, the next speaker, Madam Infantani Augusti, representing El Memento. And I request directors of Corpus Family College of Nursing, so please felicitate her with a certificate. I request Sarika Madam kindly felicitate our third speaker, Mr. Ropi Sharma, representing Memento. Pinky ma'am and Augustine ma'am are requested. Please kindly come on the dais for a group photo. Thank you, ma'am. Thank you, sir.
अब आगे से कैमरा कर लेना ना और आगे चलो अभी आज कर लो सब बात करते थे नहीं वो कह रहे हैं वो भैया एक ही हो तो वो भी भाग गया पानी पाले आने की
So now we will go for a lunch break for half an hour or 45 minutes.
कट कर